Hey everybody, it's Eugene Lisho here, and welcome to Forensics Talks. This is episode 34. And just before we get started, I just wanted to make a couple of quick announcements, or maybe even just one. But the first one is that many of you know that I'm helping to organize the Canadian Society of Forensic Science conference that's coming up this June 21st to 24th. And if you're interested in registering, there's a ton of excellent speakers from all over the world. We have an excellent program. All the information is up on the website, and all you have to do is just head over there. It's going to be csfs.ca. Again, it's June 21st to 24th, and it's not that expensive. If you're a non-member, not affiliated with the organization, it's $80. If you're a member, it's $50. Student member, $25, and student non-member, $40. So it's not that bad at all. Okay, everybody should be able to see that. And I'm going to remove that out of here, and we are going to get started with our talk today. So my guest today is Selma Eikelenboom, and she's a forensic scientist at Independent Forensic Services in Colorado. And she received a degree from the College for Social Work in Amsterdam, the Netherlands in 1976, followed by 10 years experience in psychotherapeutic treatment. Selma graduated from medical school from the Free University in Amsterdam in 1992. She worked 8 years as a resident in surgery, emergency medicine, obstetrics, and internal medicine. From 2000 on, she focused on medical forensics as coroner for the city of Amsterdam and at the biology department of the Netherlands Forensic Institute. In 2003, she started IFS out of the Netherlands, and in 2011, she moved to Colorado and opened a second laboratory. So through her forensic medical work, she became interested in a possible association between DNA variants, psychoactive medication, and violence, and that interest became the emphasis of her work, leading to a research project with the University of Denver and a PhD in March 2021. And on that note, let me get Selma in here. Hi, Selma. How are you doing today?
I'm fine, Eugene. How are you?
I'm good. Thank you. Thanks so much for being here today. I'm just going to check something before we start because something seems like it's astray. There we go. Now you're going to hear me much differently, I think. So there you go. I think it switched my microphone, so I just want to straighten that out. So Selma, first off, I just want to, we're going to be talking about your work, psychoactive medication, and all this kind of thing. But before we get started, just a quick precursor, and that was what got you interested in medicine and forensics?
In medicine, well, actually, when I was a young girl and I was going to school, I had to pass a church, and I think I was about 9 years or so. And out of the church, they came with a little white box. How do you call it?
A coffin?
A coffin, a little white. And I realized suddenly that there was a child in there, and I thought, oh my God, you can die, you can end up here. And that's when I figured out, well, you know what, if I become a doctor, then the chances of me surviving and not ending up in a coffin so soon are much better. So that's how I always, from that moment on, I wanted to be a doctor. And forensic science, I got interested in that because when I was working in Amsterdam in the internal medicine, we had a lot of HIV/AIDS patients. And one of my AIDS patients died, and I didn't know why. And I got in contact with the coroner, and the coroner said, "Well, you should come and with me on a shift." And that was a shift all throughout Amsterdam on crime scenes, on suspicious death, on people in prison, and it was quite exciting. And that's how I got into. That's how my interest in forensics was planted, and from then on, I pursued that line of work.
Well, so far so good. I guess the wager with becoming a doctor worked out because you're still around, so that's a good thing. So, all right. Well, a couple of things. If anyone wants to type into the chat window along the way, I'm going to do my best to try and look over and glance over because I do a terrible job of that. I usually focus on the speaker, but I'll try to do that. And in case anyone has any questions for you, we'll try to bring those up. The other thing is, obviously, Selma, I'm not a doctor or whatever, so you're going to have to help me ask intelligent questions here because a lot of the nomenclature and everything else is just pretty in depth. But I have taken a little bit of time to sort of understand kind of what's going on. So I'd like to start at the maybe a little at the beginning and sort of talk about the early development of these psychoactive medications. And I think you talked at one time about them being started in about the 1950s. And can you talk about like what the early developments of these drugs were, or maybe how they came about?
Yes, that's very interesting, and a lot of people are not aware of it. But actually, they started out as insecticides. They were looking for ways to treat worm infections, and they used these chemical compounds called phenothiazine, and they used them on pigs, but they were so toxic for the pigs that they stopped with that, but they developed them further, and they developed them into promethazine, and promethazine is a substance that works on the central nerve system. And that's what they wanted to do, kill the buggers with attack the central nerve system. So they did that, and then they started experimenting in shock treatment, because shock is also related to the central nerve system. And they found out that the people who were treated with these medications, and the animals treated with these compounds, they became very somnolent and quiet. And that's when they thought, maybe we should try this out on psychiatric patients. And so they developed the first one, that is chlorpromethazine, and it's still used today. It's called Largactil. That's the specialité name. And from that, they developed the first benzodiazepine. That was chlordiazepoxide. I don't know if that's the correct English way to pronounce it. Mm-hmm. That was Librium, and that was the first benzodiazepine. And from then on, well, one after another new compound was invented and brought to the market. But basically, they're insecticides.
Really? That's interesting. In one of your papers, you talk about like a new generation of antidepressants in like the 80s, or like around that time, 80s, 90s. Was there some kind of new technology that came out, or some new discoveries? Is there anything in terms of the development that changed? I mean, obviously technology has a big factor. People are researching these things. But like, were they becoming stronger? Were they becoming just whole different classes of chemicals that were being used?
Oh yeah, well, all of the above. It's once it became something they could use in psychiatry, and of course psychiatry didn't have much medication to begin with at all. So that was quite a market to develop. And when they started experimenting, they came out with one compound after another compound, and they were all, because they were desperate, they were all experimented on psychiatric patients. And from the beginning, in the 50s, 60s, they knew that it was not going to cure any underlying disease. So it wasn't going to cure it wasn't going to cure depression. It wasn't going to cure psychosis or schizophrenia. But what they did is it sedated the patient. And in that time, that was quite an establishment. I mean, that was good, because psychiatric care was horrible. So they were happy with the compounds, but then the pharmaceutical companies got involved. They saw money, and they started marketing these compounds. And even though they didn't cure the depression, they would call them antidepressants. And then they thought, you know what? Let's call them antipsychotics. Let's call them anti-anxiety, because that people will buy them, because I'm anxious. I'm going to buy, I want to go to my doctor and prescribe me an anti-anxiety pill, describe me a happy pill. Right. But basically, they don't cure any underlying disease. They sedate people. That's it.
Yeah. So I was doing a bit of just looking up like the different types of psychoactive medication, and it seems like there's four main types. So one was stimulants, the other one was opiates or opioids, another one was hallucinogens, and then there were depressants. So is the one that you were focusing on most the depressant type of barbiturates, benzodiazepines?
You mean with regards to my studies?
Yeah, with regards to your studies.
No, well, I looked at all the psychoactive medication.
Oh, okay.
Well, for as far as my subjects used them. But there are many people now on antidepressants, because even though there's no increase in psychiatric illnesses, there's a lot of demand for it, because people get diagnosed with psychiatric disease out of nothing. Even people who only have psychosocial problems, which you shouldn't treat with medication at all. So it looks like there's a lot of increase in people using these psychoactive medication. And it's also, I mean, you can say, for instance, olanzapine is an antipsychotic, but it's often prescribed off-label. So the FDA approved that for that indication, but a lot of physicians prescribe it off-label. So if somebody cannot sleep, well, let's give him this antipsychotic, which makes no sense, because if you call it an antipsychotic, why would you give it to somebody who has trouble sleeping? So in my research, I looked at people who used antidepressant, antipsychotics, hypnotics, and I researched those people further.
Okay. So I guess it would be a good idea maybe to explain in a very simple manner how the drugs affect the human system or the human body and how they get metabolized. So because your paper, for somebody that's not familiar, they see, SIP 450 or whatever, and they're like, oh, what the heck is that? So so let's start with, somebody pops a pill, and what's the, just in very general terms, what's the basic process for how that gets metabolized in the body?
Well, there are two aspects on metabolizing. Many medications needs to be transformed, needs to be adjusted to work, or they need to be adjusted to be able to expel them from the body. So and the expelling from the body, the getting rid of the medication from the body, we call metabolism. And you have certain DNA material, that's the cytochrome P450. I will go in that further, explain that later, but you have these genes, that DNA material, and the DNA material that generates a protein, an enzyme, and proteins do all the work in the body. Yeah? You have to have, those are the substances who work in the body. So the protein goes to the medication. We call the medication the substance. And either it changes it in such way that it will be active, an active medication. That's what we call a prodrug. Or if it needs to be expelled from the body because it's foreign to the body, so you need to get rid of it. And then it changes it in such a way that it's soluble, that you can either pee it out or that you can use it through the bowels. But it has to be changed to get rid of the body.
Okay.
And
so
sorry, go on.
No, go ahead.
Well, the CYP450s are the group of genes that I studied. And there are many CYP450s. There are more than 1,000. And I only looked at 3 families. And if you look at the name, CYP450, for instance, 2D6, that's what you see a lot. If somebody has a result from a laboratory, for instance, you get CYP2D6 star 1 star 1. Well, you have to realize that the CYP450, the name CYP450, that's the city, that's the village. If you go to 2, that's CYP2, that's called that the street where somebody lives. And if you go to the D, CYP2D, well, D is then the number of the house, and then then you get another number, that's CYP2D6, and then 6 is the family, and the star 1, the first is the daddy, and the second is the mommy. That's okay. How you characterize the pieces of DNA that are involved in metabolizing.
Okay. So the issue then is, I guess the main issue then is with how people metabolize the drug, because we know that if I'm given a dose and you're given a dose of a certain drug, the effect that it has on me may not be the same as you.
Yes, and that's
okay.
And well, the CYP450 is only one factor. There are many more factors, but it's a factor that's more or less predictable. You can use laboratory techniques to make a profile. You have forensic DNA where you can say, well, this person has such and such forensic profile for identification. These are pieces of DNA that can predict how somebody can metabolize medication or not. Now, for instance, in some streets, had the mommy and the daddy, there's only a mommy or there's only a daddy. And that means that there's not enough DNA material to generate the proteins to metabolize the medication. And that leads to loss of function. It means you have less enzyme, because the enzyme, that's the protein, the enzyme metabolizes the drug. If you have less enzyme, then you cannot metabolize the medication as quickly as somebody who has a mommy and a daddy, so who has more enzyme to metabolize the medication.
Okay. So was there somewhere along the way, like during your work, that sort of triggered you to say, or that sort of a light bulb went off and said, wait a second, like I'm seeing, because it's not uncommon for people in forensics, people are on drugs, like just, recreational drugs, and a lot of them on antidepressants or whatever the psychoactive drug is. I mean, it's not uncommon. Anyone who sees a toxicology report, you'll often find different types of things, including alcohol. Alcohol is a type of depressant, let's say. But was there somewhere along the way where you said, wait a second, there seems like there's like a connection here? Was it a particular case, or was it just seeing things repeatedly for you?
Well, it started with one case in the United States in 2013. And that was a woman who violently killed her husband. And there was actually no reason for it. And the lawyers asked me, can you do the CYP450 DNA? And I was aware there was something like CYP450 because I'm a doctor, but I had no idea what it meant. And at that time, we were doing the forensic DNA, so in criminal investigations. So, okay, I took up the case, and I had to go to Holland to have the profile done from that case. And the profile was, she had a very bad profile. And that I thought like, hey, that's strange. And it was, the crime was so horrendous. And I mean, we see a lot in criminal cases, but this was really like out of the blue, this normal woman completely beaten her husband to death. So I started looking around in Holland to see, we had a lot of contact with lawyers, and I asked lawyers about, okay, guys, do you have these kinds of cases? And then they come up with mothers killing their children. And that's so contra nature. I mean, for a mother to kill her children. And then I started to profile them because they were on medication as well. And they had very, let's call it a lot of DNA with loss of function alleles, variants, genetic variants. So they were not able to metabolize the medication as well. So that's when I started looking for cases where these, where you could see either the use of psychoactive medication and crimes, acts of violence, and see if their DNA was indeed how do you call it, afwijkend, different from the DNA of other people, and that turned out to be. And then I started to do a big research project to see if there was any association there. Okay, but it's mainly the violence that's included. People kill themselves in horrible ways. There's one case of a man who took a T-shirt. He was in prison, and he was of the antidepressants, and the psychiatrist in the prison said, "No, you have to take this," and they gave him, against his will, the antidepressant again. And after a couple of days, he stuffed his T-shirt in his mouth and he suffocated himself like that. That's the sort of violence you see well, take for instance the German Wings pilot, the Cher bus crash. The sheer violence of it is incredible.
Mm-hmm. Yeah, actually, you're making, so the German Wings, I think I have a note on that actually. So the German Wings, that was the pilot, it was the A320, it was March 26, 2015. And he was, I have a quote here from something I caught online. It says, according to medical records, he was taking medicine to treat depression, anxiety disorders, and panic attacks. Adding the drugs were an antidepressant and the tranquilizer, lorazepam, something like that.
Yeah.
So yeah, that's one there. And then the Sierra bus crash that you were talking about. So that one is actually, we're both familiar with that one. But on that one, the driver was taking, I think it's called paroxetine.
Yeah.
Is it
Yeah.
paroxetine? Yeah.
Yeah.
So is it what about the way that the drug is administered or taken? So is it the drug itself, or do people pop more than required? Do they all of a sudden they start up on these things very rapidly? Like what kinds of things can happen when people don't take the medication as prescribed, or because some of these people are found with no chemicals in their body when they're yeah.
Yeah, well, it is quite complicated. But the first thing is, the most dangerous times for these acts to occur are at the beginning of treatment, if you want to call them treatment, but at the beginning of the usage, when the doses are adapted, either increased or decreased, or when people stop. Now, thank God, there's more attention now to people trying to quit the medication, and it's very, very difficult. It's more easy to get off heroin than to get off antidepressants. So a lot of people are hooked on these medications for the rest of their lives. So that's one thing. The second thing is, you can get these side effects, because they are side effects, after taking one pill. There are cases enough where people are on short term, or just one pill, and they become completely off the rails. And it doesn't make a difference if you inject them, or if you swallow them. It's just that what they do is they interfere with the equilibrium in the brain. And the brain is a very sensitive organ, the most sensitive organ we have in the body. And it's a network between all these, what we call neurotransmitters, that connect one brain cell to another brain cell. And you have different neurotransmitters. You have dopamine, you have serotonin, you have adrenaline. And if you start messing with them, we have actually no idea what's happening in the brain. And that's why you can see this variance of actions. Some people have no problem at all. Some people go berserk after a couple of pills. Some people go berserk after years because, for instance, their liver is not working properly anymore. So you get an extra factor that influences the metabolism. So it's very. They should be extremely careful with giving these medication, and they're popping them like candies.
Yeah. A while back, I interviewed a toxicologist, and he was talking about. He wrote a book on like a lot of famous people who had died, and then he would go in and look at their autopsy reports, toxicology reports. But I was surprised by how many people were taking multiple. So not just like one, but like 3 or 5 even. So, and I'm going to guess that when you start mixing these things, people probably don't know what they do, the effect that they can have. Yeah. And the risk may obviously be much greater. No?
Well, it's one of the things that I found in my research. I mean, the drug-gene interactions. So that's when somebody has some deficiency in their genetic material. That's a risk factor for developing violent actions. But if people combine medication, you get drug-drug interactions, and they can lead to the same disturbing of the metabolism. It's like when you have one bicycle and you have two people who want to use the bicycle. It means one has to walk. And it's the same with medication. If you have medication and they both need the same CYP450 enzyme to be metabolized, the CYP cannot work on 2 drugs at the same time. So one drug will increase in the body and can cause toxic effects. And with the withdrawal, I wanted to add that if they have cases where people have no toxic material or no medication in their body, it doesn't mean that the brain is functioning okay, because the brain cannot adapt to situations where people suddenly stop this medication. It's what I want to stipulate. Anybody seeing this podcast and thinking like, oh, I should stop this medication. Don't stop abruptly. Go to your physician, talk to them, tell them you want to taper them off, and do it slowly. Because if you suddenly stop them, that's what was the cause in the share bus crash. That bus driver, a couple of days, did not take his paroxetine, so he wouldn't have any paroxetine in his blood. But he was completely homicidal. He killed 28 people, 22 children. I mean, that's what these medications do. So you have to be aware that if you stop them, or change the dosage, this can develop.
Okay. Yeah, that's a really great point. We've been talking about your PhD and the paper, and I want to spend some time on this too. So I'm just going to bring it up here. And the other thing too is I want just so everybody knows, I am going to post a link to this in the chat window. Luckily, this is open access, so anybody can download this. It's freely available, and there it is. I just put it in there. But let me ask you about the paper then. So what, well, let me, before we say about what you found, can you talk about the method and how you went about testing or looking at the data that you had?
Well, we had two groups. We had a group of 55 people who had either had committed acts of violence, or had an what we call altered state of consciousness. And those are the people who had hallucinations, delusions, emotional breakthrough, aggression, who didn't got really violent, but that's a precursor to violent behavior. So I had 55 people of those, and I had 58 people who were just volunteers from around the corner, from friends of friends of friends. And we took their DNA sample, and we typed the DNA sample out on several P450s. And then we looked at, okay, the people who have committed acts of violence, do they have more what we call variant alleles? Do they have more DNA deficiencies than the people who do not commit any violent crimes or acts of violence or altered emotional states? And it turned out that the people who had committed acts of violence, they had, well, if you know, you have per gene, you get one gene from your father and one gene from your mother, and a location on a gene is called an allele. That's the mommy and the daddy. So per allele, you have two possible results. And if you have what we call a variant allele, so you don't have the *1*1, because that's the normal allele, but if you have a *10 or a *5, or if you don't have an allele there at all, it turns out that the people who commit crimes have 5 or more variant alleles. So I checked on 8 SIPs, and that's 16 possible results. And the people who had 5 or more variant alleles, those were the people who committed acts of violence.
Wow. Okay.
And then I looked at okay, what kind of medication, because we looked at all the medication, what kind of medication did these people use? And it turned out that the people who committed acts of violence used significantly more psychoactive medication compared to the people who did not commit acts of violence. Mm-hmm. And then we looked at the antidepressants. So they used more antidepressants, significantly more. And they also used significantly more antipsychotic or sleeping pills, hypnotics.
So now basically now you can check to see if somebody is starting to display I guess what you call akathisia, or some kind of agitation or violence or whatever. You can check to see if they're more susceptible to this drug. Is that that's the idea, right?
Yeah. If you want to prescribe people psychoactive medication, it's so easy. It's only going to be a couple of $100. Then you get 27 different genes. So you can. And a lot of insurances pay for it today. So you can have those genes. And if you see that people have certain variant alleles, then you know, okay, I should not give those medication, or I should give them in a low dosage. But if they also, that's what I was what I wanted to say. If you combine medications, you can have a normal CYP450 profile, so there's nothing wrong there. But if you combine the medication, you get the same effects. That's what also became clear during the research. So if you know, okay, people cannot metabolize it properly, then reduce the dosage or don't give them at all, or try something else, psychotherapy, for instance. By the way, did you know that any other form of therapy, if you have psychiatric problems, if you are depressed, if you use either medication or psychotherapy or music therapy or movement therapy, they all work to the equal amount. So there's no preference to use medication, because psychotherapy works just as well. Any other therapy works just as well. So why would you give people medication if there are alternative methods that are not toxic?
Wow.
That's
Okay.
something. I mean, and I know they don't have much time for patients nowadays, but patients should have the options for, okay, I don't want the pills, I want psychotherapy.
Right.
And I'm not against medication. Get me right here. I mean, I know that sometimes it can be very useful to give people some medication to help them through a crisis, but do it only for a short period of time and get them off as soon as possible.
Yeah, because if you're on some of these medications for years, then who knows what the heck is happening, or how your system is changing, or whatever else is going on.
Well, we know they cause brain damage. They're related to dementia, people who are on this medication. And if they do autopsies in many of the cases, these people have brain damage.
Oh,
so
really?
We know. I mean, that's the whole hypocrisy in all the talking about the vaccine, and it's not the long-term effects are not known. Well, the long-term effects of psychoactive medications are not investigated. So I mean, let's talk about that first.
Yeah, well, it was interesting because in preparation for this talk here, I was looking up a number of different cases, and I just thought, let me pick some of the popular ones and let's see if there's anything related to psychoactive drugs. So, for example, like and I'm going to raise a point here. Like, for example, the Sandy Hook shooting in Connecticut, right? So I won't say his name, but the boy who did the shooting, when they did the toxicology report, they didn't find anything in his system. But when they spoke to the family, they said that he was prescribed, I think it's called Fanapt or something like that. Yeah. So, which is an antipsychotic medicine. So I was like, oh, okay. So there's a connection there. And then when I started the German Wings one, I had known about. And then I looked at also Columbine. So Columbine, I said, that's a popular one. A lot of people know that one. And it turns out that I forgot his name now, but he was prescribed Luvox or something like that. Yeah. So that's another antidepressant, right?
Yeah.
So the what's his name? The guy who did the what was it called? It was the Virginia Tech shooting that was in 2007. Yes. So he was Sung Hui Cho, that was his name, and so he was prescribed Prozac. So, but what I'm wondering is that, and based on what you're saying, the person could be on it, then decide, I'm not taking this anymore. And in fact, there was a comment made by an ex-FBI profiler. Her name was Mary Ellen O'Toole, and there's a quote that she has that says that O'Toole said that other mass shooters have had histories of antidepressant use, but acknowledge going off their medications because they want to have a clear head during their attacks. And I thought that was kind of interesting because I also read that some of these drugs, they metabolize quickly. So you have a suspect or whatever, and they don't have anything in their system, but they may have stopped 2, 3, 4 days earlier. And then what you're suggesting is it can cause a problem.
Yeah, exactly. And that's it's interesting that she would say, well, the medication made his head not clear, because he wanted to have a clear head when he was killing. And then, I mean, I would say the next step it would be like, hey, what is this medication doing to the mind? Instead of finding a reason that he was just a bad guy and it was not the influence of the medication. And that's where you always have to be very careful about, because many people say like, oh, if you come up with an involuntary intoxication or with temporary insanity, you not want to take responsibility for having killed all these people. But I mean, if they do not, our people are not aware that this medication can cause these side effects, then you shouldn't blame the people who suffer from these side effects as well. I mean, and they always say that the Columbine shooting inspired many mass shootings, school shootings after that. But that's not true, because Columbine happened in 1999, and in 1991 they started with this medication, and there was this this young boy. He was 12 years old, and he was obsessive compulsive, washing his hands all day, and they thought, let's start him on this nice new medication, and it was fluoxetine. And they gave that to him, and within days he started developing these nightmares that were so vivid that he couldn't break free from them. It felt like he was awake. And in those nightmares, he got the order to go to school, shoot his schoolmates, shoot his parents, and shoot himself. And he could hardly get out of those nightmares. So they quickly stopped the medications, and the nightmares went away. And they gave them again, and again he got these impulses. And that was 9 or 8 years before Columbine. And you see it happening all the time. This morning it became on the news that the man who shot in San Jose, he was bipolar. Well, any psychiatric diagnosis here in the United States most of the time means medication. So I'm just, if something like this happened, I'm just waiting. Okay, when are they going to say what we know about the shooter? And yes, there it is. He had mental problems, and it's not that people with mental problems are more violent than others. Research showed that that's not the case. But if you give healthy people these kinds of medications, they can become very violent. So can you imagine if people are suffering from stress or depression, and you give them these medications, that they become violent? That's not a leap of faith to assume that the medication is involved.
Mm-hmm. And that's sort of counter in some cases to what the drug was supposed to do in the first place. It's supposed to make you better, but it ends up making you more violent, or it makes you, susceptible to doing things that you normally wouldn't do at all. So, yeah.
Yeah, and that's what we see a lot. People are depressed and they go to the doctor. And I've been working on cases where people were not even depressed. They would just go for their yearly checkup. And they would say, like, the doctor would ask, how are you doing? Are you sleeping? Okay, well, yeah, I have a bit of trouble sleeping because I'm looking for another job. And then the doctor says, you know what? Here, I have a nice pill that can make you sleep. Okay, great, I'll take it. And then in this case, that goes downhill. And so this woman came back to the doctor a couple of weeks later and told her, hey, I'm not doing well. I'm getting more depressed. And instead of thinking, hey, maybe it's the pill I gave her, they say, you know what, here, take this pill, try this one. Or we'll increase the medication, or we'll take this off and put another medication. And then they start on this sliding scale, and 7 months later, the woman killed herself, and there was nothing wrong with her.
Mm-hmm. So in some cases, are the patients or the people taking the medication, are they aware that when they take these things, like, hey, I'm not myself, or is it just, it's unconscious? They just start changing. They just think that they're normal and their behavior changes. Are there any situations where, like, somebody says, this is doing something to me that is not me? And, so I guess the question is of awareness. Like, are they aware of what's happening?
Well, that's one of the reasons I agreed to do this, because I want to make people aware that this is what the medications do. But what happens a lot of time is people feel like 50% of the people on antidepressants have side effects. And one of the worst side effects is the sexual problems. They cannot reach an orgasm anymore, or they cannot hold on an erection. They have no libido anymore. Now imagine if you're not doing all too well and you lose all your sense of sexuality. So these people often say like, hey, I don't want to take these medications. And then they go to the doctor and they say, hey, I want to stop this. And then they get depressed again because you get the withdrawal effect. And what happens is that the doctor say, you see, you have a repeat depression. It's the underlying disease is coming up again. You have to take this medication the rest of your life. There's this chemical imbalance in your brain, just like diabetes, and you have to take this medication for the rest of your life. So the psychiatrists are not helping the people. Instead of saying like, hey, maybe they are not getting better because of the medication. No, they say it's despite the medication, they're not doing better. Let's give them more medication. So people are aware that the medication changes them and they want to get off. But the physicians often say like, no, it's the underlying disease. You have to take them.
So I see two scenarios where you could potentially help people. So one is, for example, just a person is going to go on medication or maybe considering going on medication, and they can get tested. And just to see, are they at greater risk or something like that? Or they could be on medication as well and they can still get the test. But then there's one where, for example, somebody commits a crime, somebody commits a murder or a suicide or whatever, and then you can also perform a test like this. So what are you imagining as the role of this, both, let's say post, homicide, suicide or something like that, and before the event happened?
Yeah, well, the best antidepressant is exercise, and that's scientifically, and not, I'm not talking about doing a bit like no, but really get out, walk, run, swim, whatever, make your heart frequency goes up. It turns out that the brain is able to heal itself through exercise, so that's the most important thing. Secondly, if you really need or want to take these medications, or your doctor says you should have them, ask for a genetic test. If you go online and you do genetic testing and medication, you'll get lots of labs who will do it. And if you have to pay for it yourself, it's something about $300 to $500, and then you get a lot of genes, and you can talk to them.
Well, what do they ask for though? If they're going to be doing this, like what do they like? What would you tell somebody? Well, if you're going to do the genetic testing, ask specifically to know this.
Well, if you just tell the lab or the provider, because you can order them online, that that you want to start using medication, psychoactive medication or psychiatric medication, whatever you want. But it's for lots of other medications as well. They use it in cancer treatment, in people who have blood clot issues, or so if you just say medication and I want to know, can I metabolize it? Then the lab knows enough. Oh, okay. And if people need help with understanding what the results are, because that's one of the problems. The results from the labs are often very difficult to interpret, even for physicians. Mm-hmm. But you can call them and ask them if they help you with interpretation, or they can contact me and I can look at their reports. That's before you start on the medication. My forensic work, because I'm a forensic medical examiner, I've done over 100 cases of people who have committed crimes. And we are currently working on two cases, one in California and one in upstate New York, for getting new trials for people who were on this medication and were involuntarily intoxicated, people who were not warned for the side effects of this medication. And it says in the product information that the physicians have to warn the family for worsening of clinical symptoms and suicidal ideation. They don't want to say like, I mean, if I was prescribing medication to people, and I can still practice in Europe, I always say, okay, I know you're depressed. There are pills, because people come like, I want to have this antidepressant. My neighbor uses it. I want the antidepressant. Then I say, okay, I can prescribe it. It probably means you lose all sexual interest. It could mean that you kill yourself. It could mean that you could kill your neighbor. But if you still want to use them, okay, sign here, informed consent that you know what you're up to. If anything goes wrong, if you feel strange, this is my cell phone number. You can call me all the time. Here you go. But most people, most physicians don't tell them, the patients, that they are at risk for this. So I'm working on the cases now where people are basically involuntarily intoxicated, and then I look at the histories, at the medication. I look at their genetic profile. I look at the other medication they use or their physical condition, and then I write a report for the courts and say, like, yes, this is it was more likely than not caused by the medication.
Mm-hmm. I can see some people though saying, well, now you're making excuses for somebody's behavior, because right now now it's the drug's fault. It's not the person's fault anymore. Yeah. Right. So some people may not react very kindly to something like that.
Yeah, I know. That's what they say. But I mean, if there's one website, it's called madinamerica.com, and you can find all the information you need about this with any scientific arguments, with the experience of people, with reviews of scientific papers. It's a very good website with how to withdraw from medication. And I'm really not saying to people, okay, don't use them anymore, but be aware what they can do and make sure that you are able to metabolize and do the genetic testing. It can save your life, and it can save the life of. And I'm not trying to fearmonger, but it's a reality. There are thousands of people. This has caused thousands of lives. Mm-hmm. And it's not only the antidepressant and antipsychotics. It's also Professor Healy. He compiled a list of 300 medications that can cause depression and suicide, and many of the regular use medications are on there. Even medications like omeprazole, for the acid return, they can cause aggression and suicide. Simvastatin, the cholesterol lowers, can cause suicide and depression. So I mean, it's very easy to say, like, oh, it was just a bad person, it wasn't a medication. But if you really start studying this, and you can look at the science that point to causality, it's not right to say that.
Okay, so what is next for you? I mean, you obviously just finished up this your PhD, this study and everything else. Are you looking at building on top of that, or do you need a break now? Maybe you need a break after that. Yeah. So, what I mean, do you have any thoughts about what's down the road for you?
Well, I'm looking into transporter and receptor genes now, because those are other pieces of DNA that are also very important, and they can say something about the possibility if somebody will have a positive reaction on any of these medications. So you can, in addition to the CYP450, that's a whole different ballgame. But if people have certain variant alleles or certain pieces of DNA on their transporter genes and on the receptor genes, then you can say, like, this person is very likely not gonna react positive on antidepressants or antipsychotic. It will not work for them. And the receptor genes can say, like, oh, this person is very likely gonna develop side effects on medication. So that's something I want to look into now.
Oh, that's pretty cool. Yeah, I mean, that sounds like something that'd be super helpful as well. We're getting on in time here, and so I think we're gonna call it here. But listen, I want to say thank you so much. It was super interesting and very informative. And I thank you so much for sharing the research and everything that you've done. It's a great job.
Okay.
All right. Hang back here. Yeah, okay. Hang back here, and I'll come back later. Thanks. Okay. All right, everyone. So that does it. Really interesting information, and you'd be really surprised. I was a little bit surprised myself. Just go to any major case or shooting and stuff like that, and have a look. And you'd be surprised sometimes. You'll find out that that there is a relationship with antidepressant or different types of drugs. Anyway, next week, we are going to have Håkon Larsson from, he's a forensic expert from the Information Technology and Forensic Digital Imaging and Audio Group at the National Forensic Center in Sweden. And he's going to be talking about the terror attack in Stockholm on the 7th of April, 2017. So on that note, we're going to leave it here. Thank you very much, everyone. And I hope to see you next week. Take care. Bye-bye.